Our first speaker is Stephen Lewis, a health policy and research consultant based in Saskatoon, and an adjunct professor of health policy at the University of Calgary and Simon Fraser University. Prior to resuming a full-time consulting practice, he headed a health research granting agency and spent 7 years as CEO of the Health Services Utilization and Research Commission in Saskatchewan. He has served on various boards and committees, including the Governing Council of the Canadian Institutes of Health Research, the Saskatchewan Health Quality Council, the Health Council of Canada, and the editorial boards of several journals, including Open Medicine. He writes frequently on topics such as reforming and strengthening Medicare, improving healthcare quality, primary healthcare, regionalization, and health policy and politics. Please welcome Stephen Lewis.
Well, good morning, everybody. It's nice to see such a large gathering in such lovely weather. Can we just calibrate the audience a little bit? How many of you are students? How many of you are faculty? How many of you are practitioners of healthcare? How many of you are other? Well, I won't ask you what you do, but we're glad to see the diversity. So, what I'm going to do in the next 20 minutes is give you my cook's tour of what this problem really is and what it really isn't. I hope it is interactive, so I want to speak for as little time as possible, and the day will be a success to the extent that you participate in it. I'm going to give you some views that may seem intuitively sensible to you and some that may seem counterintuitive to you. So if you want to debate them, so much the better. And I'm sure that there will be an implicit debate among the speakers, if not explicit. So, as you can see from my title, I'm not actually all that persuaded that sustainability is an issue. In some senses, I am in others, and by the end of this, I hope you understand why I think what I do. So, when we talk about the healthcare system, to me it doesn't make any sense to talk about what's good and bad about it unless we agree on what we want to achieve. And I think we want to achieve these things. One of the speakers, particularly on Bullet 2, Value for Money, Peter Hawley will no doubt be talking a lot about this one. I think that's a very important issue in healthcare, not how much we spend, but what we get for it. And we've talked a lot about all these other things. The second last one, the Japanese term muda, meaning useless work. You probably don't hear a whole lot about this, but quality experts will tend to coalesce around the number up to 30% of healthcare spending is either useless or harmful, which is a big proportion, and we can argue about whether it's 30 or whether it's 20 or whether it's 15, but it's not trivial, and I'll show you why it's not trivial and why we do this. And I would also suggest that unless there are major opportunities to get better, to improve the system without making draconian trade-offs about access. So this is what spooks people. This is a graph, as you can see, of total healthcare spending, inflation adjusted. And look at the bottom line, which is the dollars spent in real terms. So these aren't actual numbers, they're $1997. And look at the slope of that line. As you can see, in the last dozen years or so, the slope has gone up quicker than at any time in Canadian history, post-Medicare history. And that's what worries, worries people. That's what Dr. Feasby referred to as the eating other sectors lunch, which would have been another line which says proportion of provincial government spending spent on healthcare, and that's been going up too. And so people say this is unsustainable. And in the usual method of sometimes irresponsible soothsayers, you take a few points in time and you project them out to infinity, and you can get 120% of GDP spent on healthcare, which of course becomes a logical impossibility. But I don't want to belittle this. That's a very steep rate of increase, and again, it's neither here nor there. We spend, the slope for spending on microcomputers would look a lot steeper than that over the last 30 years, and nobody seems to mind that. Certainly, and certainly the makers of iPads and now Research in Motion aren't upset by that, because we think we get good value for these things. So it's not what, it's not on what, but what do you get for what you're spending. Well, I'm going to give you 4 what I think are pretty good explanations of why we have a cost curve like that. And the punchline is, it's not an accident. There's no automatic entitlement of healthcare to keep generating its own spending. We have designed the system to be expensive and to keep being more expensive, arguably, than it needs to be. And I'm going to give you a few minute explanation of why I think that is so. And the most important one, in my view, is that the system is designed to drive up costs. This may sound silly to you, but actually the way we pay people, the way we fund organizations, what we do and do not exercise some discretionary control over, what we worry about, we don't exert normal financial discipline in healthcare like we do in other sectors. Healthcare is not a market good. It is not like guns or butter or truffles. This is a sector where the provider side, the supply side, has most of the knowledge, and people defer to it. I'm not saying illegitimately, and we as citizens tend to do what the system encourages us to do. We do not exert independent financial prudence on the system. And then on the supply side, everything about how we pay the supply side will tend to drive up costs and volumes. And the biggest reason for that is that we have in Canada equated productivity with doing more. That is the simple, oversimplified to a certain extent, but that is the general principle of healthcare spending. I'm a consultant, so I'm a fee-for-service guy. And if you said to me, Steve, we're going to pay you by the word, you get to decide how many words you write and what you write about, and you will send the bill to the state, which will pay it, unexamined. You can bet I'd write a lot of words, very frequently, and you would have a lot of needs that you never knew you had. And that is essentially the logic of a fee-for-service payment system for physicians. Now, I'm not saying that physicians all behave badly. I'm not saying that there is a malicious attempt to extort more money out of the system, but that's how it works. And then without proper and prudent oversight of value for money there, you're getting a very high-cost system. So graphically, I would suggest it looks a bit like this. Now, this is an oversimplification, and this isn't empirically derived. But by and large, this is how we divide up healthcare spending. We spend the great lion's share of it for showing up and doing stuff, and we spend a tiny portion of it that is in any way related to performance. I actually think that's probably a fairly accurate fraction in Canada. There is very little spending at risk because of lousy performance. People want to change it, but it's changing very slowly. The second one is that we have a very medicalized culture. We are taught to believe, and this is part of the general worldview that is not just healthcare, gadgetry, ingenuity, technological advances are inherent goods, and the more of this stuff, the better. You can't get enough good technology. So we have medicalized a whole lot of things. We get a lot of advertising from the United States for various pharmaceutical products that permeate the cyber barrier. We're not allowed to directly market drugs to consumers in Canada, but if you have cable TV, that is a very thin barrier against being bombarded. So erectile dysfunction is probably the most commonly used word in advertising in Canadian television that comes from Detroit, Spokane, and so forth. So you have all these new drugs, new devices, and we actually are very much as a public preoccupied with the sickness care. So as I mentioned here, we declare war on cancer, we declare war on diseases, but we don't declare war on the failures in the social determinants of health. We don't go to battle for health. We declare war on sickness, which is a very expensive proposition, and I'll show you a little bit later, not particularly successful at the margins. But that's part of the general zeitgeist that we live in. The spirit of the times is very much technology-oriented, intervention-oriented, and we are encouraged to be medicalized. 20 years ago, if you had a headache, you would take an aspirin. 15 years ago, you might take a Tylenol, perhaps with a codeine upgrade. Now you want a CAT scan. And this is, it sounds trivial, but it's actually true. The skyrocketing utilization of expensive technologies to figure out what ails us. So our collective fascination with these things is a very, very, very serious cost driver. And then, of course, this is abetted by interest groups. We're all part of interest groups one way or another, whether it's the interest group for lower tuition or an interest group for beta interferon for MS patients or Herceptin for cancer patients. And these are all very successful. Social marketing is the name of the game. Interest groups in healthcare are numerous, successful, savvy, sophisticated, and collectively they pursue an agenda of driving more money into the sector, playing on people's hopes and fears and fascinations with what they do. Again, I'm not judging whether or not this is a good or a bad thing, but it is an explanation for why costs keep going up. Thirdly, and there will no doubt be some interesting dialogue about this today, I think we grotesquely misuse human resources. And the general law that is operative here is that people are encouraged by the way we pay them, and they are encouraged by their professional guilds and associations to work at the lower end of their capabilities. So we've had 40 years of very high quality evidence that nurse practitioners can do 60 to 90% of what physicians can do, yet very few of them work at full scope in the system. Primary care doctors are doing work that could be done by others, specialists are doing work that could be done by primary care doctors, nurses are doing work that could be done by licensed practical nurses, and so on down the line. There's almost an inverse law. The more highly educated that you are, the less likely you are to be working at your full scope of practice. This is a systemic problem, and never mind the inefficiency built into this, I think it's demoralizing for people who work in healthcare. We keep giving them higher and higher credentials. It's now master's entry for occupational therapy and physical therapy. Nursing went from diploma to degree. So we get more and more educated people who in their academic formation have higher expectations of an advanced scope of practice and a more intellectually stimulating life, only to find out that the work is the same, and that having all of this extra training does not actually entitle you to a greater professional role. And it's a lose-lose, I would say. Tom Feasby mentioned that we have increased medical school enrollments. It's by 70% in the last decade in this country. More than that if you count the easier path of international medical graduates. This is going to cause a flood, in my view, of high-end talent coming into a system where spending restraint is likely to be more part of the equation than it has been for the last decade. So this is a nice summation of this. This is a long-time expert on health human resources. And then I won't read it to you because you can see it, but the quote essentially says that the professions themselves are largely responsible for overly protective practices that support a guild and turf mentality rather than a collaborative interprofessional mentality. You can have your own take on this, and I'm not saying this is gospel, but I think, again, that is another explanation for why costs keep going up. And in case you think the numbers matter a whole lot, take a look at this graph. And take a look at the left side of the graph. This is a graph that plots life expectancy, which is not a bad proxy for a country's health status, versus number of physicians per capita. And over on the left side, you know, the faint blue area is actually life expectancy. So just take the left-hand 25% of that graph. The dark blue lines are show the variations in number of physicians per capita by country. And if you can find a correlation between the number of physicians per capita in that country and anything to do with health outcomes, you're a statistical wizard and they'll name a test after you. Because there is none. It's a random effect. It doesn't matter how many doctors you have per capita. It doesn't matter how many nurses you have per capita. There is no relationship in advanced countries between the number of people you have in the system and the health outcomes the society gets. So don't get fixated on numbers, get fixated on what the numbers are doing and whether it makes a difference to the population. The fourth thing is we're appalling price negotiators in healthcare. We're essentially price takers. We got a new thing, it cost us a lot to develop. We'll tell you it cost a lot more than it did because it makes it look like we need to get more out of you, and you'll just pay it. That's an oversimplification. It isn't always the case, but it is largely the case. So Canada is notorious. We're notoriously taken to the cleaners on generic drugs. Best example being that Ontario finally got fed up and by law cut the price of generic drugs in half in one day, and nobody's losing money. So there were billions and billions of dollars going out the door unnecessarily. And we tend to pay cost plus in terms of what it costs to produce the new good, the technology, the service, rather than looking at it, what does this service do for us, and shouldn't we pay roughly in accordance with what we get out of it? No, we're going to do that. So it's the same as if McDonald's said, it's cost us $38 to produce a Big Mac, so will you pay $50? Instead of, would I pay $50 for a hamburger? But that's, again, oversimplified, but that is a lot of what we do in healthcare. It is notoriously highly priced compared to other industries, and there's not very much discipline in Canada. And of course, in some ways, it's even worse than that. In a fee-for-service mentality, if I'm a doctor and I very successfully teach you how to self-manage your 3 chronic diseases, so you only see me once a year and you stay healthy, that's a spectacular healthcare success and a fee-for-service failure. I lose money. On the other hand, if I fail at encouraging you and helping you and mentoring you to self-manage, and you come back and see me once a month, I make more money. That is in a large matter how the system is designed. It is designed to pay me for volume, not for succeeding in helping you be healthy. And again, this is the curve that should scare you a lot more than the cost curve in itself, which I think is inherently rather meaningless. This is again life expectancy versus spending by country. The dots are countries. Since this was produced elsewhere, Canada isn't identified, but we're in there. We're somewhere between that little, there's the United States, Switzerland, Japan. We're in the Japan cluster, veering towards Switzerland. So as you can see, if you just look at that part of the graph, it's totally flat. There is no relationship whatsoever between additional health spending and improvements in health status. That's the worrisome part. What are we getting for all of this extra health spending? Whatever we're getting, it's not, in obvious terms, better health status. We may get better access, we may be comforted by it, we may like the bells and whistles in the system, some people may be helped, there might be moderate quality of life advances, but it's pretty hard to get extra value. And the reason for that is that the middle classes and up are by and large pretty healthy. We don't know how to make a middle class population healthier en masse. We do know how to make poor people healthier by investing in the social determinants of health, and that would be huge health gains, but we'd rather not do that. We'd rather keep spending money on health care for us, the middle class, than for the people who could benefit from a diversion in spending. So, that's Canada. What do high-performing health systems do? Well, they do things differently. And I'll give you a list of examples in a minute. They focus on quality a lot more than on cost. They really make efforts at the front end of the system, primary health care, early stage intervention, helping people to be healthy. It's not nirvana anyplace else. It's not like we're horrible and they're perfect. But some subsystems in countries and some whole countries, if you look at Northern Europe, have done a much better job than we do. They do not define productivity as volume, and I think that is the single question that underlies the sustainability issue. If we continue to say that productivity means doing more stuff, we are going to do more stuff. We need to shift the conversation to what is the stuff getting us. They're a lot more driven by scientific evidence. We have enormous variations in practice in Canada. There will be some counties in Ontario that do 4 times as many hysterectomies per capita as another one, and nobody is looking to narrow the variation. And that kind of variation is an obvious quality problem. We have a million examples of these in the country. They do a somewhat better job, I would argue, of optimizing the division of labor. And what they really do, if you want to get control of your costs, you can spend huge amounts of money in the community, on specialists, on the diagnostic end, in community interventions if you keep people out of the hospital. And some countries do a much better job than we do of reducing hospital utilization, because that's the sharp end of the system and very expensive. So are these fairyland systems? I mean, is that just an ideal type that someone made up? No. Here are 5 examples of systems that are demonstrated to be a good deal better in terms of quality and cost than ours. They do some fundamental things differently, and yes, you can argue that there are flaws in all of them. I think they are systematically better than we are. And what do they obsess about? Well, they obsess about these things. How do you have a really patient-centered healthcare system? How do you prevent? How do you prevent circumstances from getting worse so that you need more expensive care and you're in worse shape? They actually focus on eliminating waste. They do apply techniques such as lean engineering principles to get rid of useless work, whether it's extra steps on a nursing ward to get to a supply cupboard, or a labeling system for drugs so you don't have to spend 5 minutes checking whether one drug is actually the one that you wanted, to eliminating steps in the chain of healthcare that you receive when you're a complex patient. They get rid of useless work better than we do. They focus a lot more on teamwork, and they do not champion clinical autonomy as an intrinsic goal. That is another characteristic of Canada, that clinical autonomy is defined, is embedded in professional identities to a far greater extent here than in many other systems, and I think it's the wrong goal. The goal isn't autonomy, the goal is excellence. And where you need to exercise your professional judgment, use it, but where you can standardize work, you should standardize it. Part of this is a factory function that offends some professionals to a certain extent, and not all healthcare can be standardized and routinized, but a good deal can, and where it can, we should do it. And they are much more concerned with value for money. So even though these systems, some of them in Europe in particular, have older populations than we do, they spend less percentage of the GDP on healthcare than we do. And what don't they obsess about? They don't have big conversations about offloading costs onto patients. Some of them do, but most of them don't. They think it's a public responsibility to do this, and it's not a big philosophical argument. They're not obsessing about cranking up volumes in medical offices and stacking up patients on wait lists, because that's the key to a higher income. They have managed to decouple those to a certain extent. They're a little more prudent about adopting innovations. Some innovations are wonderful, some innovations are not. Both a large American investigation and a large French study have shown that about 78% of all new approved drugs confer no significant therapeutic additional benefit compared to existing drugs. Yet we adopt the newer ones with great regularity at great cost for very little additional benefit. And they don't obsess about incentivizing performance at the individual level. They don't say, you know, if we paid you for this and paid you for that, or if we tweak this and tweak that, you're going to be a better practitioner. They talk more about the culture of practice than about the financial mechanisms. They do not economize healthcare in the sense of, they don't treat physicians, nurses, and others as if they are pure profit maximizers at the individual level who only do good things if you pay them. They have more respect for them than that, and I think we fundamentally disrespect physicians when we treat them as if they need to get paid extra for doing a good job, and that if we don't pay them extra for it, that they won't. I think we've created the monster that we observe by persisting in the way we pay them. And finally, they don't obsess about sustainability. If you punch in sustainability and name your country, Canada has far more hits per capita that come up on Google than other countries. It's not an issue, it's not the question, it's the wrong question. Of course, in a sort of conceptual sense, it's a question that if you spend 60% of your GDP on healthcare, is that sustainable? But actually, we have very good mechanisms to control health spending. Once a year, governments set a health budget. That's what's going to get spent publicly. Some years, though we don't remember this, they spent less than they did the year before. Alberta whacked its budget, I'm not saying wisely, in the early 90s. So did Saskatchewan, because of fiscal circumstances and so on. So it's not hard to control health spending. What's hard is to get good value out of health spending. And I hope that becomes the theme of the conference. So that's my opener. I realize we'll have said a lot of things that you can rightly disagree with, so over to you for the comments and questions.
I have a question. Regarding your comments on fee-for-service, and that is, are you asserting that some physicians, at least in Canada, are willing to overtreat their patients? And by overtreat, I mean treat past the point of maximum outcomes to the point where the patient's welfare deteriorates or gets worse.
Of course. There's research on the subject. There's a great study in New Brunswick about the correlation between how much primary care docs earn and the number of prescriptions written and the length of the visits. So, yeah. And again, I don't think it's very few would say, we have this great scheme and I'm going to milk it. It is built into the culture. So they have observed that if you see 60 patients a day instead of 14 patients a day like they do at Group Health in Seattle, their income goes up a lot. And you can get rid of the patient from your office in about 3 to 5 minutes if you end it with a prescription rather than talking about the underlying condition. So I worry less about bad apple behavior than the insidious effects of a culture that reward volumes and very, very targeted episodic interactions than more, I would say, productive, sustained conversations about health, maintaining health, and producing health. So that's what concerns me.
I'll just add, I'm aware of a study in the state of Washington in the 1980s regarding Medicare care costs in hospitals that draws a similar conclusion to the one that you referenced.
There's never been a debate on the philosophical side of it. I think you could say that Canadians want socialist medicine, give us everything anytime at any cost, but forget that we operate in a capitalist system, which is based on money. The doctors are capitalists, so to say, because they're businessmen. The nurses are on the same boat because through their union they can dictate the prices. So perhaps we should look and say, which system do we want? Do we want socialism? And I'm not politically involved in anything. Or do we want a capitalist system so you pay as you go? So there should be some political discussion. And in the last 50 years that I've lived in Canada, I've never seen anything like that happen. Go to the doctor, purely fill a bill, the state will pay. This is the socialist handle. Then you go to the States as well, you only have X amount of money. How can you pay for it? So all of us have to start thinking, how do we go about it?
Well, you forgive me for slightly reframing what you've said. I don't think it matters what regime you're under. You cannot have a coherent healthcare system that meets society's needs that doesn't involve fundamental redistribution. Meaning, healthy and well-off people must subsidize the care of the poor and the sick. There is no other way to do it. If you decide not to do that, if it's just a pay-as-you-go system, poor and sick people will not get and use health care, and they will have terrible health outcomes, and well-off people will be induced to use more health care, much of which they probably don't need. So redistribution is going to take place under any mechanism. The question is, do we conceive of health care as a market good? Is it just like buying TV? And I would argue no. It can be a long conversation. I would just assert that healthcare fails the test of being a market good in very, very, very many fundamental ways. And the simple illustration of that would be, for any market good that is truly a market good, if you lower the price, you're going to sell more of them. So let's say that somebody offered you a sigmoidoscopy for $2. Would you have one because it's so cheap? Would you have two if they cut it down to $1? The answer is no. There's nothing intrinsically enjoyable about consuming healthcare. So I don't think it does. Now, the part that I think you're right about to a certain extent is there has been a commodification of healthcare. The lifestyle-oriented healthcare, the desire to medicalize every normal variation in human condition so they can sell us more stuff, be it a drug or an intervention or some kind of therapy. That is, if you like, a pure capitalist response to supply and to marketing. And I think that's part of the problem. So I think the nature of health and health care do not lend themselves very effectively to a commodified approach. And until we have a conversation a bit deeper about that in our society, I think we're going to remain in trouble to a certain extent. Yes, sir.
Thank you for your talk. I'm a consumer of healthcare, not a provider. And I think what I've learned in your talk is to start training my doctor to talk to me rather than write prescriptions. I think that's very valuable learning.
Well, I'm going to give you an example of a system that I mentioned, group health in Seattle. This is in the States. I mean, this is not socialist heaven. This isn't Cuba. Here is a system where they have organized themselves around very successful primary care. They do a great deal of their care with the internet and by telephone because it's more convenient for the patients. They schedule, these are doctors in the United States in a highly competitive environment. They schedule their visits at half an hour, and a typical family doc will see 14 patients a day. They will see them for serious things and have serious conversations. And when it's not serious and they don't need them, they will have a phone conversation that takes 2 minutes. So they've organized themselves fundamentally different for the purpose of keeping them healthy. And the result is, as an insurer as well as a provider of care, they buy far fewer specialty services and hospital services. They have repatriated $30 to $50 million of referrals to specialists because primary care does a better job, mainly because they are driven by evidence and they spend time with their patients. So I think, and we went on a study tour and we took a couple of docs, and they were bug-eyed when they saw these statistics and about this, that yes, there's a better way to do it. And we need to get our heads around some of that kind of stuff.
So are those doctors compensated based on number of patients?
They're salaried. They're deliriously happy to be salaried. They get 17 applications for every position that's vacant. They pay them well, but they don't pay them spectacularly well. They pay sort of what the average GP in the States makes. But the working conditions are fantastic, and the relationships with the patients are over the top. Yes?
So, Stephen, great introduction to the symposium, and I really agree with very much what you say. These organizations you've referenced, which we've had some discussion about, that provide a much better model of care, I certainly admire them as well. But if we look at the Canadian reality, politics, democracy being an inherently difficult system to manage, and we say, how about Alberta? Could we convert Alberta into a Kaiser Permanente, or an intermountain health, the whole province? And I'm sure Stephen Duckett will address some of this later. It'd be a great thing, I think. Put all the docs on salary, change the incentives, teamwork. But is it a political reality, or do we disagree?
Well, I was going to say, I think given enough time, Stephen Duckett, I don't know what Stephen Duckett would want to do, but I think he would want to do some of this, and I suspect you could at least declare your intentions and start to work towards it. Again, it's a very complicated scene, as you say, but I think we overcomplicate it. I think everybody, including organized medicine, knows that the fundamental driver of all of this stuff is the agreement between medical associations and governments. I think governments have done a disservice by giving medical associations what they think they want, rather than blowing these things up and starting over. Most docs I know, especially younger docs, they don't have a particular visceral allegiance to being paid a certain way or another way. Most of them want some blended system. And physicians, like the rest of us, we hate change, but when we change, it's better. We wonder why the hell were we objecting to change. So I think we need to have a serious conversation about that. And again, it will be about decoupling productivity from volume, changing the metric of what we're after. Also, you're the Dean of Medicine, you're in a health science faculty, university. What are we teaching people about the sociology of professions and about the what is an appropriate way to reward excellence and so on? I don't think we teach enough, to tell you the truth. I understand the curriculum's busy, but the socialization process begins pretty early. I say idealistic young medical students every year, and they're kind of Médecins Sans Frontières kind of people. They're in it to do good, and by the time they end up practicing 5 to 7 years later, they're just like everybody else. So we sort of drive them into a culture that actually they wouldn't normally embrace. I'm not saying I know how to get this done, but you have to start there. And I think having conversations in a safe space with physicians in particular is very important, and you don't want to be negotiating this as step one. You want to be talking about it. What do we want? What do we think a reasonable way to pay for it is? What are our interests that are on the table that we want to protect, and where are we prepared to be flexible? I think you would get some good uptake. There already is in Alberta some reasonably good uptake on alternative payments and trying to revamp primary care, but it's pretty slow, and you get the early adopters, and then it kind of fades, and then you sign another agreement at 2 in the morning after 15 cups of coffee, and you give away all the reform impetus because you've just extended the status quo with a bunch more money. So I think we need to figure that out better.